Okay, good morning, everyone. I have 8:02, so I think we'll get started. And I know there'll be a couple of folks that will be joining us in a few minutes, and we can just go through the usual announcements to start with. So a reminder for this session and for all sessions not to disclose any private health information. This is our usual information about contacts for the ECHO series, a little bit about cardio, and this is the entire ECHO team. Today we have a case, actually Jim and I will be presenting, but we have a case from Austin Friedrichsen, and our discussants today will be Jim and Danette. So this is our range of participants from across the state, and we will get started shortly. So this is a combined session. So last series we had a session on smoking cessation, of course, critically important for cardiovascular risk, but also environmental pollution. And before Jim gets started, let me say this unequivocally. There is, unless you live in a coal-fired plant that has no pollution controls, smoking is by far the much worse cardiovascular risk than environmental pollution. So any of your patients who believe that their air is polluted, and that's one of the reasons they're at high risk. And if they smoke, the first thing to do is to advise them to quit and to help them to do so. So with that introduction, let me just go to the next slide. And these are disclosure statements, which haven't changed, by the way. And we'll get started. Jim, whenever you're ready.
Great. Thanks for that great introduction and setup, Goutham. So I'm going to talk about tobacco use. Next slide. So my job today is to describe the prevalence of tobacco use in different subpopulations in the U.S. and specifically in Ohio, and talk about culturally sensitive approaches to smoking cessation, and then provide some resources that you can use to help patients. Next slide. So adult smoking rates in the U.S. have declined over the decades. The all-time high prevalence was in 1954 when 48.5% of adults, almost half, were smoking cigarettes in the U.S. And this has steadily declined since the 1964 Surgeon General's report linked smoking to significant health problems, including cancer. And so today in 2022, the rate of smoking in the US is 11.5%. This has been really the result of many different efforts, mass media campaigns against smoking, good education for children about the dangers of smoking, big restrictions on advertising, smoke-free policies that came into being in the last 15 years or so, better cessation treatments and better insurance coverage, and really, very importantly, taxes on tobacco products. And they make a very big difference, particularly in low-income populations and in younger people. So we want to encourage taxes whenever we can. And Big Tobacco fights those those efforts, spending over $70 million in California alone to defeat an initiative a couple of years ago. So taxes are very effective, though. Next slide. So let's look at Ohio's tobacco use, cigarette use. Ohio tracks along at a higher rate than the US. Right now, 17.1% of Ohioans are regular smokers, have the 8th highest smoking rate in the US, and we're in a high smoking region bordering West Virginia, which has the highest smoking rate at over 25% of adults, and Kentucky, Indiana, and Michigan. Next slide. So looking at it by subgroups, so we do have differences in the raw data, as you see here, but the only one that is really statistically significant are those that are designating multi-race. And this is a rapidly growing segment of our population, growing at 3 times the overall, the rate of the overall population. So we want to really be sensitive and helpful in prevention messages as well as helping patients stop smoking. But overall, we have an acceptably high rate of smoking across our population because any exposure to tobacco is harmful. And so we want to keep working on this. And Ohio has a lot of room for improvement, as you saw with our rate of 17%. Next slide. So there are big disparities in rates by educational attainment, and this tracks along with income as well. So over 40% of those with less than a high school education are smokers in the state of Ohio. Uh, those with high school diplomas, 1 in 5 are smoking, and it stair steps down from there. Associate's degrees are intermediate between high school and college, although this is not on here. But educational attainment is really important in preventing smoking, actually. So unfortunately, Ohio does rank 37th in the 50 states with percentage of our population with a college degree. So we have a large segment of our population with lower levels of education. So there's significant at-risk population. Next slide. So looking at insurance type, the population we're focusing on here with our ECHO series, our Medicaid population, 39.5%, almost 40% of Medicaid recipients are smokers. And this is significantly higher, 15 percentage points higher than the US average for Medicaid recipients. And then for those with other forms of government health insurance like TRICARE, Indian Health Service, and other programs, they're smoking at a rate of about 30%. So this is a significant challenge for us to help the Medicaid population reduce the prevalence of smoking. Next slide. E-cigarette use is high in younger people. Alarmingly, 1 out of 10 middle schoolers is a regular user of e-cigarettes. In high school, that's twice as much, 20%. Some good news, that came down from 29% in 2017, I believe. So it is on the decline, but it is very high exposure to nicotine, which is harmful to the developing brain up to about age 25, we know. So exposure to nicotine, even without exposure to the other tobacco byproducts, is really harmful. And the 18 to 24 age group has the highest rate of e-cigarette use in Ohio. And what this has done is really supplanted cigarette smoking with one form of nicotine replacing another in those populations, those younger populations. So in 1999, for example, 40% of high school students reported being regular smokers. Today, it's 3.3%. So that rate has come down dramatically, but it's really been replaced by e-cigarettes instead. So younger people have to be, at least 21 years old to purchase vaping products in Ohio. We know among the particularly Hispanic and Latino population, a very high percentage of them are purchasing these products, these vaping products at local stores. So this is still going on. And so a lot of work still needs to be done in this area. And rates increased during the COVID pandemic, as you might imagine. Next slide. So we already talked about low income and non-high school graduates, but we also have other groups at significant risk for of using tobacco. Those in poor mental health in particular are really at significant risk. So Americans who use tobacco and have a co-occurring mental health disorder comprise about 7% of our population, but they consume 35% of all cigarettes smoked in the US. And about half of people with schizophrenia, bipolar disorder, or depression will die of tobacco-related diseases. So this population bears a very significant burden, health burden, due to tobacco use. It is very possible to help these populations quit smoking. However, evidence has shown that recently. And so they can quit like other people. So I really encourage clinicians to do those, spend the same amount of time helping these people quit as you would anyone else, because evidence shows that they can quit and stay quit just like as the general population can. Those with disabilities are also more likely to smoke. Those with Appalachian residents also more likely to smoke. And the LGBT community has typically been significantly at higher rates of cigarette use, but in this particular analysis this year, they are not. But that's a population that we should watch and pay attention to going forward. Next slide. So we've got these populations at increased risk, as I mentioned. So these are 7 different populations at increased risk for tobacco use. Next slide. So let's talk about some quit methods. In 2021, those who were quitting smoking or making quit attempts, 33% used medication, and that's very good. 16% did not use medication when making a quit attempt. And then we know that about 10%, 11% attempted to quit smoking using e-cigarettes. And this rate seems to be increasing. We know that also about 30% of adult current smokers did make at least one quit attempt in 2021. And the vast majority of people who smoke want to quit smoking. But only about 60% were really aware of the Ohio Tobacco Quit Line. Smokers were aware of that. So we need to expand awareness of that. It's a tremendous resource and is very effective for helping patients quit smoking. Next slide. So let's look at e-cigarettes for cessation. So a study that was published in 2023 showed that people using e-cigarettes in quit attempts were actually less likely to have successfully quit cigarettes compared to those using a pharmaceutical aid like nicotine replacement therapy or bupropion or varenicline, or no product at all. So these are really not effective ways for people to quit smoking. Those who were able to convert over from cigarettes to e-cigarettes, 60% of those became daily e-cigarette users and relapsed to cigarette smoking. 60% relapsed. And isn't that 40% were able to stay on e-cigarettes, because this doesn't include a very high number of people who use both e-cigarettes and regular cigarettes concurrently. So not very effective. And as you all probably know, e-cigarettes produce these toxic byproducts that can cause significant lung and heart disease. Next slide. Looking at behavioral cessation methods, physicians and nurses are in ideal positions to help patients quit smoking. There's strong evidence for its effectiveness. I've already mentioned telephone quit lines, tailored self-help materials. A Cochrane review showed that using tailored self-help materials to tailored as best they can to the patient by their health condition, by one of the subpopulations that I mentioned, can actually be very helpful for encouraging patients to think more about smoking and follow up the conversations that you may have with them. We know that brief in-person counseling of less than 10 minutes by primary care provider does increase the proportion of patients who quit smoking and remain abstinent. So these brief conversations of 3 to 10 minutes, they're reimbursable. And so they really do make a difference. Even minimal interventions of less than 3 minutes have also been found to increase cessation rates. So clinicians are in an ideal position to help patients with smoking cessation. Next slide. So as I mentioned, about a third of adult smokers use medication, but only 7% use counseling. This is outside of a primary care setting, and only 5% are using counseling and medication at the same time, which is the most effective way we know to quit smoking. Next slide. Oops, go back up, please. Here we go. Up, forward. There you go. Okay, so the 5A's model is an ideal framework for helping patients quit smoking. You're all probably familiar with it to one extent or another. So you can ask the patient about their smoking status. For example, do you use tobacco products, cigarettes, or e-cigarettes? And then advise and assess. So and a message like quitting smoking is the most important thing you can do for your health. And if you can, link it to patients' current health problems if they are smoking related. As someone who cares about you and your health, I'd like to help you quit. And I'd like to hear your thoughts about quitting smoking. So asking this open-ended question, which is consistent with motivational interviewing, which I'll talk about in a minute. Would you be willing to quit smoking in the next 30 days if they are interested in quitting? So asking these questions and simply guiding the patient on a quit attempt. And then if they're not ready to quit, a message like, I feel strongly about tobacco use and its effect on your health. I understand that quitting can be really hard, but I'm here to support you. And if it's okay with you, I'll ask you about it at a future visit and get permission to keep the door open there. So this is a cultural humility is approach that was actually developed in healthcare for healthcare. And it's an approach to just really attempting to genuinely understand a patient's identities, their own personal identity, in particular with respect to race and ethnicity, gender, disabilities, socioeconomic status, education, social needs, all those different subpopulations that I was talking about earlier. It really meshes with cultural competence very nicely, which you all may have had some training in, which is really more about knowledge-related health beliefs and cultural values. And this is more at the personal level of knowing that there's always more we can learn about the evolving and dynamic nature of a patient's experience. And it causes me to think of that ancient saying that no man ever steps in the same river twice because it's not the same river and he's not the same man. So not only is the world in a constant state of change, but people are as well. And so we can help them learn and find out about how they're being shaped by their experiences that may help with smoking cessation by better understanding them. Next slide. So motivational interviewing, I won't have time to go into that in any depth, but it's very consistent with cultural humility because it's really about learning what's important to the individual and what they value, and then helping them resolve ambivalence about smoking by kind of contrasting their smoking behavior with their values and what's really important in their life, and helping them kind of hold those things up to the light and examine them for themselves, and helping guide them through making steps to quit smoking. Meta-analysis found that the effect size for MI was actually twice as large for minority populations compared to the white majority population. So it's very effective across different segments of our population. Next. So we have this tremendous resource available for free, and it is Ohio Tobacco Quit Line, providing coaching over the phone, plus email, text, chat, follow-up, a nicotine replacement therapy available. So they report a 37% quit rate for those who are using both their coaching and their NRT, which, as I mentioned, is really the best practice, and high satisfaction rate. Next slide. For those who are more interested in non-direct approaches like texting, smartphone apps, social media, smokefree.gov is a great resource for that. So they really have great tailored apps to different populations: women, teens, veterans, Spanish speaking, over 60. Go ahead, next slide. And then American Lung Association has the Freedom from Smoking program, and really nice for people who want group approaches. So they have online support groups for helping patients quit smoking, as well as in-person groups. Next slide. So electronic health records can be programmed to facilitate referrals to make these easy for you. And the Ohio Tobacco Quit Line and others have IT staff who would work with the IT staff at a health system to integrate that into electronic health records and optimize that workflow. Next slide. So there are many additional resources for quitting smoking. For example, there are online groups, there are 12-step groups, and other groups available depending on patients' preferences. So no shortage of resources. Next slide. So just to recap, Ohio has one of the highest smoking rates in the nation. There are significant disparities in tobacco use. And the 5As and motivational interviewing and cultural humility work together and really blend well to facilitate smoking cessation discussions. And you can refer patients to these excellent resources that we have in Ohio. And for those who aren't ready to quit, keep the door open by requesting permission to resume a discussion at another visit. Next slide. Okay, Goutham, I'll turn it over to you.
Thank you, Jim. Terrific presentation. Lots of great, valuable information there. So I'm going to talk about air quality and environmental pollutants. And let me just say at the outset, I don't have any expertise in this area. Everything I know comes from Dr. Sanjay Rajgopalan, who's also our division chief of cardiology and probably the world's leading expert in the environmental effects of the cardiovascular effects of pollution in the environment. So we'll talk about 3 environmental pollutants, disparities in exposure to these pollutants among different racial and ethnic groups in the U.S. as a whole, and a couple of resources to identify communities prone to increased cardiovascular risk due to environmental pollutants. So some of you remember it was about a year ago that there were wildfires in northern Ontario and Quebec that generated an enormous amount of smoke, and they were so remote that they couldn't be put out. And this is what New York City looked like in the middle of the day one day last summer. And of course, even here in Northeast Ohio, we had a similar phenomenon, though not this extreme. And I think people had a very poor conception of how dangerous this actually is. I can remember some of the school districts in the area just contemplating whether they would cancel outdoor activities or not, softball and football practice and that sort of thing. And I remember writing not a nasty letter, but saying, you definitely need to do that. Keep the kids indoors today. And it wasn't because people were trying to be defiant. They didn't understand how severe and how serious air pollution is. So it is the primary type of pollutant that we're going to consider today. Obviously, there's other pollutants that are associated with cardiovascular risk, chemicals, water pollution, etc. And the one that we're most concerned about is PM 2.5, which are particles that are less than 2.5 micrometers in diameter, so much smaller than a human hair, which you can see by comparison here on the right. And they're mostly made of sulfates and organic carbon. And you can see that, for example, by reference, a grain of sand is 90 micrometers, so almost 40 times the size. And of course, there's ozone gas as well, which of course is a gas, but which is also a serious cardiovascular risk. So these are the 3 that I think we need to focus on: sulfates, carbon, and ozone gas. So first off, air pollution is convincingly linked to cardiovascular morbidity and mortality. There's no doubt. And these are models that have been developed over time and refined and are adjusted. But we estimate that in 2015, that PM 2.5 resulted in 4.32 million deaths globally, 103.1 million disability-adjusted life years lost just in that 1 year, 7.6% of global mortality, and 4.2% of global disability-adjusted life years. Now, the majority of these are taking place in 2 countries, China and India, which collectively have about 40% of the world's population, but where air pollution is a very serious condition as they rapidly industrialize. But the number of deaths attributed to ambient air pollution was more than those attributed to heart disease, stroke, COPD, lung cancer, lower respiratory tract infections, all combined. So extremely serious. There is a dose dependency, as you might expect. So in other words, as you get exposed to higher levels of PM 2.5, the cardiovascular risk increases quite significantly, both in terms of heart disease and stroke mortality as well. Very, very serious. At some of these high levels you'll find in cities like Delhi, Beijing, even some cities in Latin America, Mexico City, for example, at certain times of the year. So you will see a significant increase in mortality during those times. Now, there is an effect that I think I want to point out that's important, and that's the harvesting effect. And this slide is interesting, but I really don't think you need to know too much about it. But what it essentially says is that, well, yes, mortality increases at times when air pollution is especially severe. And we saw that here in the United States, for example. At one point, I believe New York was the most polluted city in the world. But are people really dying at a higher rate because of the air pollution, or are the people who are dying already have severe heart failure, coronary heart disease, and their death is just being precipitated more quickly by the air pollution? In other words, they were at high risk for mortality anyway, and that's what it seems to be. So that people who are at high risk, elderly folks with pulmonary conditions, cardiovascular disease, are more likely to die during episodes of high environmental air pollution. So the consequences are serious. We talked a little bit about stroke and cardiovascular mortality, but you don't have to talk about mortality. I mean, it's even just morbidity as well. So atherosclerosis, each 5 microgram per meter increase in PM2.5 is associated with progression of coronary calcium, 4.5 units per year. Hypertension, and this is actually really is astonishing to me, that if you are exposed to environmental pollution, and it will raise your blood pressure. If you put an air filter system in that environment, let's say, your systolic blood pressure actually goes down significantly. You'll see a 2.5% relative increase in risk of MI per year. It's associated with all kinds of things: heart arrhythmias, heart failure, peripheral artery disease, clots, diabetes, and stroke as well. All of these increase independent of other factors. What can we do about this is a big question. All of these increase independent of other factors. What can we do about environmental air pollution? Well, this is, of course, well beyond the scope of primary care and Medicaid providers and what we can collectively do. As a society, we can look at it as a public health problem. So some of the major causes are vehicle emissions. We can participate in reforestation. But I think the most important thing is we tend to think of mitigating climate change as essential for our long-term future, in terms of sustainability of agriculture and where people live, etc., natural disasters. And of course, those are all extremely important. But decarbonization can actually now be considered to be a health strategy. So even if you're not too worried about those things, you say, oh my gosh, the sea levels are rising, it's not going to bother me, may bother my grandkids. And if that's what you think, well, decarbonization as a strategy to complement climate change mitigation for health reasons is another way of thinking about it as well. What individually people can do is the following. So every single location in the United States will have a reported air quality reading. And this is from Cleveland, Akron, Lorraine, or actually from Chagrin. This is like last fall sometime. But you can put in your zip code of residence wherever you like, and it'll give you an air quality reading on a government-sponsored website called Air Now. I personally think that our patients who have heart disease, pulmonary conditions, and anybody, I think, over the age of 75 or so should probably, we know they all have smartphones, right? This should be an app on their phone where they just look at it like anything else, their weather forecast, right? You want to know how cold it is outside, you should probably do that. A lot of people use their smartphones as soon as they wake up. They want to see what messages they had. They want to look at Instagram or Facebook. This should be one of those things that they do. And I would say, if the air quality is fair or poor, and if you are one of those high-risk individuals, you should be indoors for that particular day. That's pretty straightforward advice, and it's a fantastic resource. The other thing that we could recommend is an air filter, air purifier. And I wasn't clear as to whether these actually work. People seem to buy them a lot. When I was growing up, we had humidifiers and vaporizers. My mom was really into it, and I didn't think they did very much. But these apparently are very helpful. So an air purifier like this is about $50, and you can put it in your bedroom. And it's not going to filter out all harmful pollutants and certainly not infectious agents and stuff, but it can be helpful in mitigating COVID-19, for example, to some degree. And I personally think every senior citizen in Ohio should have one of these, regardless of what their underlying conditions are. And very inexpensive, relatively simple, I think, to install and to use. So I want to point out that, relatively speaking, and Jim did a fantastic job of summarizing smoking cessation, But smoking is of course associated with poverty. These are, it's certain racial and ethnic groups have higher risks overall, certain age groups, etc. This, by far overwhelms any effect from environmental pollution. So lobbying for cleaner air is important. And I will say most parts of the United States have much cleaner air than many other parts of the world. But the cost of 1 pack per day in Ohio amounts to $2,416 annually on average. And our Medicaid patients are paying this out of their limited disposable income. Okay. $2,400 is about $200 a month. That's a fair bit of money, after you could do some meaningful things with. You could certainly buy a HEPA filter air purifier as well, or several of them, right? So there's a lot of good things you can do by quitting smoking. The poor do suffer, however, disproportionately from air pollution. As you might expect, there are some racial and ethnic differences. This is not, this is clearly about where people live, and, nicer neighborhoods are never downstream from large factories. And in this hemisphere, the northern hemisphere, whenever you say, oh, he lives on the east side, that usually in most cities denotes a less desirable area. In Chicago, it's the south side, but the south side is really east. East something usually means East St. Louis usually means that it's a more impoverished area, and that's just because that's the way that the wind blows. Interesting, in Australia, you want to be on the east side. You want to be by the beach and all the nicer areas. It's the west side that you need to avoid. But so these differences are not necessarily because they are due to their proximity to sources of pollution rather than any other factors. And of course, these differences are not huge as well. Even better off people can be exposed to significant amounts of air pollution. So here's some key lessons. So PM 2.5 is what we are concerned about. Of course, they're very large particles, they can be very dangerous, but they're usually, if somebody is starting a campfire, right, you're going to keep your distance naturally, and you're not going to breathe too much of it in. But the PM 2.5, you cannot control. You can't control how much you inhale. Carbon and sulfates are the principal culprits. Ozone is a major gaseous pollutant, which has a less impressive impact, but nevertheless has a significant impact. Avoiding polluting environments and circumstances is especially important for patients with cardiovascular risk factors and cardiovascular disease. What I would suggest, and I think we do so much. I still see a lot of masking, especially among our senior citizens, which I think is quite responsible. So people are taking their health very seriously. We talked about smoking cessation. We can talk about exercise. I'm suggesting two very simple maneuvers. Monitor air quality every day, and to use a filter when air quality is poor. Those are not huge things that hugely burdensome things, either in terms of cost or effort. And I think that young people, of course, are much less affected by these things, but nevertheless can also be conscious of it as well. But anybody who's older, especially with predisposing conditions, should take those two measures. Thank you. So we're going to stop, and before we get to Austin's case, perhaps if there's any questions for Jim or for me, now's a good time to ask them.
Dr. Rao, this is Paul, if I may. Fascinating, both of the presentations. Interestingly, the air pollution, if combined, it's a more prevalent cause of death. Why do we continue to put coronary heart disease as #1? Why don't we elevate air pollution to the #1 position?
Yeah, that's a great question. Coronary heart disease, I think, is easier to measure. And I think, Paul, it's just people are very skeptical. It's like, oh, that can't possibly be true. It should be true. And I was skeptical before I started to look into this and speak to Sanjay about this a little bit more. So absolutely, we should rank it #1. In fact, if we were to mitigate air pollution to a significant degree worldwide, we'd see a huge drop in cardiovascular morbidity and mortality, no doubt about it. Any additional comments or questions? So Andy, back to you.
Another reminder that we have our cardio webinar coming up in just under 2 weeks. You can register on the cardio website or through this QR code. Next slide. You can access all past and present echo recordings on our website through these 2 links. And then a reminder that a post-clinic survey was sent to you. Please respond to it by tomorrow by 5. As Goutham said, please submit case studies if you haven't already. If you have an extra one, feel free to submit that as well. We'll take any case studies we can get. Thank you.
All right. Thank you, Andy. Thanks, everyone. Have a wonderful rest of the week, and we'll see you next week. Bye-bye.